Welcome to the podcast of the Consortium for History of Science, Technology, and Medicine.
Hello, and welcome to today's panel, Medicine Crossing Borders. I'm Dr. Rachel Louise Moran. I'm a professor of history at Texas A&M, and I'm going to be moderating today. So I don't think I have to tell you how important questions of immigration and citizenship, borders and belonging are to our current political moment. In the U.S., we are negotiating it daily, maybe even hourly, these ideas about who belongs and who doesn't, which is right now being aggressively and violently policed. So our panelists today bring unique and critical insights to questions about how we've reached this moment, filtered through their various expertises in the history of medicine and nursing, both contemporary and historical. And I think these approaches will bring a lot to our conversation. I want to quickly introduce the four panelists, then give them an opportunity to tell us more about their academic work. Then I'll have some questions for them and they'll be able to speak. So first, I want to introduce Ira Malam. She's an associate professor in the history of science at Harvard University, and she specializes in the history of medicine with a particular emphasis on globalization, race, migration, and health in the 20th century. Her first book, The Care of Foreigners: How Immigrant Physicians Changed U.S. Healthcare, is out on Tuesday, we just learned, so please make sure you get your copy. Congratulations. And that book explores the enduring consequences of post-colonial physician migration to the United States. Then I'll introduce William Lopez, who is a clinical associate professor in the Department of Health Behavior and Health Equity and a faculty associate in the Latino Studies program at the University of Michigan School of Public Health. He's the author of Raiding the Heartland, an American story of deportation and resistance, which was just released at the end of September, so buy that one too. His research, writing, and advocacy consider how communities survive and thrive under the threat of mass deportation, especially in the rural U.S. Joel Calixto is a doctoral candidate in the Department of History with a concentration in Native American Studies at the University of California, Davis. His research explores the history of air pollutants, technology, and medical racism along the U.S.-Mexico border. Part of his research will be published in the forthcoming Routledge Handbook of Health and Environmental Humanities. And his work has been generously supported by the Mellon Foundation, the American Council of Learned Societies, and the Huntington Library. And finally, I'll introduce Andre Rosario, who is a presidential postdoctoral fellow at the School of Nursing at Rutgers University. And he's been also a practicing psychiatric nurse. Andre completed his PhD in nursing from the University of Pennsylvania and was affiliated there with the Barbara Bates Center for the Study of the History of Nursing. His dissertation was recently awarded the Teresa E. Christie Award from the American Association for the History of Nursing. Congratulations. So to start us off, can you each take a couple of minutes to tell us what you've been researching and working on, whether it's your dissertation or your brand new books that you want to tell us about, and to introduce a little bit about how questions of immigration, migration, medicine, and health drive your work.
All right, so I will begin. Thank you so much to the consortium for hosting this, for Rachel moderating, and my fellow panelists. I am very eager to learn from all of you. So my path to a lot of these questions about immigration was not really what I expected. I was trained as a U.S. historian of medicine, and I realized that all of the stories that felt to me the most urgent were in fact things that exceeded the nation state, that made the US a very porous kind of entity, and that I had to start looking and asking questions in a slightly different way to get at what I wanted to get at. And so movement, migration became really, really vital analytics for thinking about how the operations of US healthcare work. So my first book is about physician migration, predominantly from post-colonial Asian nations to the United States, and that's the book that will be out next week. And in there, I, explore this history of, for the last 60 years, at least a quarter of the US physician labor force are immigrant physicians. And in rural and underserved areas all throughout the country, they are more than a quarter. They're anywhere from 50 to 100% of all of the people that are providing care. And so I wanted to think about that dynamic and try to understand how is it that this stratified labor force has come to be in the United States, where US trained physicians are working with wealthy insured patients, and immigrant physicians are sent to provide care for the most marginalized in society. And so that's the first project. And as I move out of that, then the next question is, well, what do patients do? So I have physicians going in, and now I'm thinking, what are patients going to do, especially in light of all of the recent cuts to Medicare and other kinds of, the Affordable Care Act, et cetera. And so what's going to happen? So now I'm interested in medical travel and trying to figure out, well, what happens when patients have to go elsewhere in order to provide care? So that's kind of the broad program of my work.
Great. Thanks so much, Iram, and congratulations on the book. That's very exciting. Rachel, thanks for putting this together, and it's great to speak alongside my fellow panelists. I'm originally from San Antonio, Texas, lived there 18 years, and then lived in Houston for 3, so I will always be a Spurs fan and happy to be speaking on the panel with someone at Texas A&M. So I will actually start with a story before I introduce myself. So my first book was called Separated: Family and Community in the Aftermath of an Immigration Raid. And I focused on a home raid that happened 7 miles from my house. So right in our neighborhood, right? This is in the middle of our county where many of us are familiar with the area. And ICE and the SWAT team targeted a man who I'll call Santiago. And Santiago was arrested in the morning, but these arrests kept unfolding during the day until ultimately a SWAT team and ICE raided Santiago's home, in which lived his wife and his sister and each of their 2 kids. So about 4 kids, another child was not in the home at the time. And as a public health professional, my interests were many, but I've continued to be interested in immigration and refugee studies. And I wanted to see what it was like to be Santiago, to be the target of a raid, and to be deported and removed, and to leave folks behind. And as I prepared to interview him, his family actually told me, no, it's not safe to go to that part of Mexico. That's where he was leaving. You can't do that. So for those of you who are, I think everyone on the panel, as you write your dissertations, you can imagine what it was like to see your dissertation question kind of, I don't know, perhaps crumble, right? The sampling scheme you had was no longer legible, was no longer possible. And I remember what I did very clearly after that. I picked up about half a dozen donut holes and I drove over to his sister's house, and I had donuts with her and her 2 kids, who later became great friends to my 2 kids. And I talked to her sister Fernanda, and I talked to many of the others involved. And what I came to understand is that I always had this public health perspective, right? What does public health teach? Individual illness, individual sickness is impacted and impacts in turn the family unit of which it's a part, which in turn impacts the community of which it's a part. And I realized how our public health perspectives were not thinking about deportation from this social network pattern. That if you remove someone in that node, whether it's a family, a team, a church community, that everyone in that web of people is impacted. So I continued to look at deportation from this community-minded mindset, right? From this web of interaction mindset, systemic mindset. My second book, which you see here, Raiding the Heartland, An American Story of Deportation and Resistance, actually just came out September 23rd, so a few weeks ago. So also very excited. It's new, and I just still get excited when I see it in bookstores. But what I looked at there to wrap up this, just the introduction, was worksite raids, the 6 large-scale worksite raids that happened in Trump 1.0 throughout the country, mostly in the Midwest, to see what we can learn, not only about how deportation impacts entire communities, because it's very evident at the scale of the worksite raid, but also how communities resist and respond, right? No individual and no community takes attacks on their health or attacks on their family and doesn't try to do something in response. And so often as healthcare professionals, we focus on what's making us sick, even if that's systemic, that we often neglect to see what keeps us healthy, especially after our confrontations with these kind of systems. So, William Lopez, I go by Bill, School of Public Health at University of Michigan. Happy to be here with you all.
Thank you so much. Well, and thank you so much, Rachel, for gathering us today. I'm super excited to be here and a little nervous. But my name is Joel or Joel, and a little bit about myself. Up until May of this year, I was undocumented. Now I'm a permanent resident, but my experience as a migrant from southern Mexico in a place called Guerrero, Mexico, which is tucked between Michoacan and Oaxaca, led me to my research in thinking about the land and thinking about the coast and thinking about gold specifically. Gold is very important in many cultures, especially in Mexico. And I became interested in how mining companies would dig up minerals and ores across the Americas, transform the health of marginalized communities, indigenous communities who live on rich soils that are prime targets for extraction efforts, primarily by, more recently Canadian mining companies. But I became interested in like the health effects, and I began to ask, what are the lingering health effects that these processes of extraction create? How do public health officials in the US or in Latin America respond to the needs of a community once the project is completed and the earth is transformed? And this led me to my dissertation. I'm still very much in the program and hopefully finishing up this year. And my dissertation examines how Latinx and indigenous communities reshape the US Mexico border by mobilizing against the harmful effects of air pollutants emitted by one mining company that straddles the El Paso Ciudad Juarez border during the 20th century and the effects that continue to kind of impact communities up until today. So, in my project, I follow how Mexican and Native American communities struggle against this environmental violence and how they respond to this, this global corporation that is receiving a lot of the minerals extracted from North America and Latin America. And I argue that, these communities challenge and expanded meanings of public health that up until that time, I would say like the 20th century, broadly mid 20th century, failed to really conceptualize US Mexico border communities that shared public health issues. So I look at like different archival materials, company, public health, stuff from the Center for Disease Control or the Environmental Protection Agency to kind of unearth the details of poisoning of children, of laborers, and the environments by this smelting company and its technology that, mind you, was supposed to deter the harms of these air pollutants, mainly arsenic, sulfur dioxide exposure, lead poisoning, and how they fail to consider the lives of migrants, laborers, and indigenous communities on both sides of the border. And the how and the why this happened is kind of the focus of my research currently.
Hi, everyone. Thank you so much, Rachel, for bringing us together today. And I'm really excited to be part of this panel with you all. I'm Andre Rosario, and I'm a postdoc at Rutgers University. My research focuses on the migration of nurses from the Philippines to the United States. And in particular, I focus on different policies over the past 30 years that have allowed for this migration, whether that's been immigration policies, state level licensure policies for requirements for nurses from other countries. And I also focus on the ways that nurses from the Philippines themselves have organized to assert their own interests in these policies. And that's been through professional organizations and also through coalitions of Filipino American organizations that are critical not only of US policies, but also of policies in the Philippines that have encouraged migration of labor to other countries as well. I have a personal connection to my work as well. My parents are from the Philippines. My mom was a registered nurse and she had studied nursing in the Philippines, but had worked her entire career in the United States. I grew up in New Jersey where there's a lot of Filipino nurses, and growing up, the same families that we went to church with on the weekends were the same families that my mom also worked with. And so they were also everyone I saw. And for a while, I just thought of it as like the Filipino nursing stereotype. And for anyone who's been watching medical dramas such as The Pit lately, there's, little side mentions of Filipino nurses. And so I thought of it as sort of a stereotype, but in nursing school, I had the opportunity to look more historically and to take a step back from my clinical work and think historically about nurse migration. And even though I grew up around that environment, and even though my parents had talked about their stories migrating to the United States, it sort of blew my mind to use history as a way to think more broadly about legacies of US imperialism and how that had related to migration policies and downstream to the fact that me and so many of the families I grew up with had parents who were working in hospitals around us. It's been interesting coming back full circle with that. I think with a lot of the immigration crackdowns, some of the things that have affected migrant workers from the Philippines have also, a lot of those situations have come to the fore as well. And so bringing the historical knowledge I've tried to build over the past several years and bringing that back to the community to help them to understand what's been happening or making sense of policies in the Philippines and stateside that have created the circumstances where these situations have erupted has been really meaningful. And so I think that's something that all of us can celebrate with this week and with the focus of our focus on the history of medicine and how it relates to immigrants and immigrant communities.
Thank you for so much for being here. I'm really excited to hear all the things that you have to say. So I wanted to start by historicizing the moment and thinking about immigration in that way. So in what ways do you see current debates about immigration and public health echoing historical patterns? And are there ways in which you see significant departures from the past that we should be paying attention to in our current moment?
I can start. I think one of the things that I've noticed in my work is these declarations of shortage. So for the last 60 or so years, and Andre and I, our work is very, very synergistic. So he looks at the shortage of nurses and I look at the shortage of physicians. And so there have been these declarations, again, of shortages of these health professionals that have continually been the case. And so in response often to the fact that there aren't enough people who are able to provide care, immigration often gets used as this stopgap measure to quickly fill the vacancies. And so this gets used over and over and over again, which raises, of course, all sorts of questions. How is it that we have the same problems and that they're the same answers every single time, which is let's just bring in more immigrant physicians or immigrant nurses to do this work and not kind of rethink what is at the base of causing this issue or this shortage. And I think one of the departures at this moment is that there is this different relationship and different understanding of how, especially with the latest executive order and the H-1B visa fee increase, that has really changed how all of this is going to look. So just a quick example. If you are an immigrant physician, you're sponsored by the hospital. Often these physicians are working in under-resourced communities. They're working in hospitals that already are operating with really razor-thin budgets, pretty much. And so for them, for initially to sponsor a physician, it cost anywhere from $2,000 to $5,000. So for that to go up to $100,000 is a really, really significant increase. And for many of these communities, the whole entire staff is comprised of immigrant physicians. So all of a sudden you go from a situation where you might have to pay, let's say $20,000 in order to sponsor people. And now it's $1 million to sponsor people to come and fill your staffing needs. And so I think this actually is quite a significant departure from this previous moment, because previously, okay, we have a shortage, there's a crisis supposedly, and of course we should problematize that because it's crisis is the state of the system. It's not as if it's a surprise if this continues to happen over and over and over again and immigrant physicians come. And now we're at this point where because of the ways that visa and immigration are being structured, because of the kind of extreme violence and paranoid relationship that is an America First kind of vision, who's going to suffer are going to be the patients who receive care by these practitioners, and because they just won't be able to come.
As I think coming off of that too with nurses compared to over the past 20 years, I think another thing that's sort of intensified is that there's been an industry that has cropped up around international recruitment and staffing agencies, especially for nurses, but also for other healthcare workers, whether that's home health aides, personal care aides. There's a whole industry of staffing companies that have tried to match healthcare facilities with laborers abroad, whether in the Philippines or in other countries, to jobs. In the past 15 years, too, there's also been a little bit more attention to the ways that this staffing industry has been more exploitative of migrant laborers. In 2007, there was a group of nurses called the Sentosa nurses who were recruited from the Philippines to work at this long-term care facility on Long Island, New York, and who found themselves in a pretty dire situation. The recruitment company set up housing for them, but it was pretty substandard, and they had multiple people sharing the same bedrooms. When they went to work at their facilities, they found that they weren't paid the same rate that the direct hire employees at the facility were also paid. And when they tried to break their contracts early, the recruitment company levied fines of between $20,000 to $30,000 to sort of trap them into these recruitment situations. And so that's been something that's been cropping up with migrant healthcare professionals from the Philippines and from other countries who have been using these staffing agencies. One thing that I think has been unfortunate is that oftentimes when these stories have come up in the past 15 years, they seem very kind of like one-off instances, like of the like crazy company of everything that went wrong. But I think that one strength with looking historically is that you're able to see these patterns of exploitation, notice that there might be red flags that more advocacy could address with these situations. So I think that's been one departure for nurses and nurse migration in the past 15 years that maybe an early generation didn't really have to contend with. There's just been a larger recruitment industry that's been creating different difficulties for newer generations and newer crops of migrant healthcare workers.
Yeah, I can give two examples, right, that come very quickly about like historical patterns that we're seeing reproduce themselves, right? And the first, I think, going back to a point that Andre made earlier, we know that in order to enforce deportation at the scale that the current administration wants to enforce it, and specifically at the level of violence that the current administration wants to enforce it, that there has to be public buy-in. And administrations always create this public buy-in in kind of similar ways, right? And one is that we see the disease trope. And I hate this, and it makes me angry to talk about, but it's important to talk about, right? And is to say that immigrants are bringing disease. And we saw that, unfortunately, during the Biden administration with Title 54, a public health law, right, which restricted the border flow. And we've seen the disease narrative. We've seen the use of public health in the past to enforce immigration and prevent folks from arriving to begin with. We also know that in order to meet violence, the public has to perceive immigrants as violent. So we're seeing more and more language about everyone being part of Tren de Aragua, for example, right? And this is how you see justification of the raids that we see in Operation Midway Blitz in Chicago. I will give one more example of a way to put this in historical context. So if you all saw Saturday Night Live this weekend, you saw Bad Bunny and K-pop Demon Hunters on it. This is really a notable moment, right? You have two singers who are singing in predominantly different non-English languages. But we also know Latino and South Korean were the primary populations that were deported from Elabel, Georgia, last month in a historic worksite raid. 475, about 500 people, right? This brings me back to the unfortunately named Operation Wetback in the U.S., when we brought folks from Mexico in to cover for the soldiers who were fighting World War II in Europe, only that when those soldiers came back, only to remove all of the Mexicans that were here. So deporting Latino and Korean workers while consuming their products at the highest possible stage goes into a long U.S. history of doing exactly this to immigrant communities. The one thing I'll say that is perhaps different is the scale and the vitriol with which this is happening. So the violence is surprising, and just to give one example, going back to Midway Blitz, we see the agents recently who descended from helicopters, cut through the apartment roof, and removed and zip tied people in that apartment, right? This is not the general scale of this magnitude that this is happening. So I believe it is unique, and we want to keep our eyes on it, as well as the use of the National Guard across states, as we were discussing before this panel happened. So National Guard being sent from one state to another state is fairly unprecedented and deserves our focused attention as well.
Yeah, and I really want to echo the narratives on disease and public health threats that kind of intertwine with debates of immigration, as Will mentioned. There has to be a public buy-in for this specter of the immigrant being a threat to the nation to continue to flourish in the political arena. And whether it be Chinese migrant workers in San Francisco, or whether it be Mexican braceros in El Paso or Texas, or even Irish laborers in New York, from they've all had or had their existence in this country be correlated with harmful stereotypes of public health. And, these specific communities were not only foreigners to the nation, but they were also sick and contagious threats. And they were directly linked with the kind of immigration that is being negotiated on in the U.S. of who do we not allow into the borders. And, sadly, like these histories and, as we've been talking, the present realities have led to ideas of race influencing medical diagnoses and public health policy. And I would say maybe an example or departure, I actually just learned about this just this year, is like the rapid growth of climate migration has been a hot topic in the discourses around migration and who comes to the quote unquote global north and nations, and why is it that people are leaving their homes? It's something that is really, really on my radar. And one example of that is a community called El Bosque, or the forest, in the Mexican state of Tabasco, which is near Guatemala and along the Gulf Coast. And just last year, the Mexican state recognized this as the first official climate change displaced community. And in 2024, this coastal community was taken over by rising sea levels, and public health concerns have grown as, the few families that are still living in the area, have intermittent electricity, fresh water is no longer usable, and they're only provided salt water at times. Cases like this, or like this one in Mexico, have led to residents buying drinking water from tanker trucks, or having no health centers, no schools, and students attending classes in makeshift facilities. And although this is not directly tied to the US necessarily, or I argue it is, right? There's this growing concern about this new quote unquote type of migrant that is coming or being produced by the conditions in our world. And the Chicago Journal of International Law published an essay that noted that by the year 2050, 1.2 billion people will be displaced from their homelands, and these will be a new class of people called climate refugees. People being displaced in the context of disasters and climate change. And these people lack legal recognition and protection. So I always wonder, if these people lack these recognitions, how will they access public health services wherever it is that they migrate to? So I think it's imperative that we continue to think about the importance between immigration, public health, and this ever evolving issue that is environmental change. So maybe not so much a departure, but also like a look towards the future.
So, building on a lot of what you all have said and a lot of the tensions that you've pointed out, I'd love to know more about how you see current political debates about immigration, current anti-immigration policy and violence intersecting with the growing reliance on foreign trained healthcare professionals in the US and globally. How do these things coexist, and how has that coexisted historically as well?
You take a stab at it. So I would say it's always existed in tension. There's never, there's always this problem with commitments to capitalism, commitments to globalization, and in that there is a desire for labor to be dictated by free market principles. So if that's the case, then labor should be able to move wherever it is that it is best suited. It's the very, very crude free market logics in operation. Yet you have that confronting these nation states and nation state ideologies, which are very much, tethered to racial logics, to other kinds of, nationalistic commitments. And so I think that those things are always going to rub up against one another in ways that historically we've seen and we continue to see today.
So, a question for everyone is, what stories or voices do you think are still missing from the historiography, the historical record as well, when we talk about immigration and health? And how do you see scholars like yourself making progress in those areas?
I think in relation to immigration, I think of there's such a rhetoric about immigrants stealing jobs that I think one voice that I really want to hear is immigrant healthcare workers and professionals in the labor movement in the United States. In the 1980s, when there was a very acute nursing shortage in the US, there was the Immigration Nursing Relief Act of 1989, which created a visa program, the H-1A visa, which had been in place until 1997. It doesn't really exist anymore. And in the news, you've been hearing so much about the H-1B visa, but the H-1A visa was a visa for nurses. And at the time, there were labor unions that wanted this visa program to be able to exist to bring more immigrant nurses into the United States. And so it's interesting to have organized labor want to bring in international labor. And I think it's a testament to how severe the nursing shortage was at the time and how much the demand for healthcare labor can supersede more restrictionist immigration policies. I think for nursing in particular too, there's not that much of a discussion about what a union is for nurses. I think even coming up through nursing school, we never talked about what it meant to work for a unionized employer or a unionized hospital. And I think it's somewhat of a avoided topic among nurses and even just among in the subfield of the history of nursing. In the past 30 years, the American Nurses Association, multiple state chapters actually have left the American Nurses Association, including the California Nurses Association in the 1990s. The New York State Nurses Association left the ANA in 2012, and the CNA went on to form a union. The New York State Nurses Association also went on to form a union and to stand by nurses as laborers and as employees. And in both states, there are very large sectors of immigrant nurses from the Philippines and from other countries. In the New York example, one of the former presidents in the 2000s was Lolita Campas, and she was president of the New York State Nurses Association, and she had actually also around the same time served a term as the president of the Philippine Nurses Association of America, which is the ethnic minority organization representing Filipino nurses in the US. So there's a lot of overlap there, but not so much of a story that's among nurses or among the history of nursing. So I think one voice is immigrant laborers in the labor movement in the US.
Yeah, it's a great question, and I think one thing that I notice when looking at worksite raids, and I think this often happens when we focus on deportation, as we look at the immediate harm, right? And we look at perhaps the day, maybe the week after, but we rarely look at long term what this does, a month, a year, and even multiple years. When from thinking from a health perspective that the trajectory of an illness is something that's critically important to understanding that illness and its treatment, right? Yet we don't, for many reasons, focus on removal and its impacts in the same way. Again, from a public health perspective and thinking about health as a network of people, we are beginning to understand the impacts on mixed status families, on spouses, and on children. I think that's critically important. But we haven't really pushed this to mixed status communities. Just to give one example, worksite raids happen, generally speaking, during the workday, and with few exceptions, during the workday, students are at school, children and teens are at school. So in multiple places we've been to, including the area around Sumner, Texas, and the area around Bean Station, Tennessee, where two large-scale worksite raids happen, the first responders were teachers, because it's the teachers who have to tell their students that the parents who dropped them off will not be the parents who picked them up that day, right? And this happens every single time that there's a big worksite raid during the day, because without exception, children are at school. So we're also missing the voices of people like teachers, as just one example, who are also impacted by removal, but are not related to the people who were removed, are not in the same racial group often as the people who are removed, different citizenship status, different economic class, and even different political parties, right? So I would want the history record to not only think about the long-term harm of deportation in multiple ways, but also the ripple effects outside of immigrant communities, because this is something that concerns all of us throughout the country.
Well, we have a bunch of audience questions, so I'm going to turn to some of those for a minute. Melanie asks, in connection to bringing in immigrant nurses and physicians, how did U.S. providers and professional organizations usually see or talk about the professional skills of immigrant nurses and physicians? So especially in comparison with American standards and practices. So especially for Aram and Andre, I think.
Well, thank you for that question. What in my research I've noticed that some of what happens here is the language of competence becomes used, and it becomes this alibi for thinking about what these people are able to bring. And so it's not as if that it becomes a very, very racially loaded term. So immigrant physicians are found to be less confident or competent, rather, less assertive, less willing to, just take the lead. And these are the seemingly innocuous metrics that end up being used to, I think, essentially make the argument that the quality of care that they're providing is not equal to their US trained counterparts. And I think implicit in that is also this fear that an immigrant physician isn't coming with the tacit knowledge that one gains when you go through a US medical education or the training. And so they are not subjected to the same kinds of social controls that US trained physicians have been a part of. The shorthand, the ways that people use to talk about other people and situations in the clinic. And so I think this really becomes these other routes of discussing these physicians as being less than their US trained counterparts. But all of the research shows that they have fewer malpractice cases than their US trained counterparts. Patients showed equal or higher satisfaction with the patient care that they receive. And so, those metrics are in contradiction to this kind of larger discourse of, well, can they actually do this stuff? Are they as assertive? Are they as good?
Yeah, and I think in addition to like a language of competence, it's just very interesting how it lines up with how immigration policy is written in the US and in terms of language around like low skilled versus high skilled labor. I think that's another way that that manifests. It's interesting now with this conversation around currently about the administration's plan with H-1B visas. The president of the American Nurses Association recently posted something regarding how the new policy wasn't going to affect a lot of internationally educated nurses because the H-1B visa is usually for higher skilled laborers and professionals. And in the United States, because in the US, one can become a registered nurse with an associate's degree, there actually aren't that many nurses who come from other countries to the US through an H-1B visa. And so it's just interesting the ways that like this like low skilled, high skilled rhetoric kind of is arbitrary. It just moves to whatever needs to make room to get whichever laborers we need that are in high demand into the United States. So that's been interesting. In the 1970s, there was a lot around like trying to suss out like the competence of foreign educated nurses. And in the 1970s, the American Nurses Association teamed up with the National League for Nursing to form the Commission on Graduates of Foreign Nursing Schools, or CGFNS, which basically created a qualifying examination for nurses from other countries to take and to have to pass before becoming nurses in the US. And it's just been interesting too, because as immigration policies and as nursing has changed, that organization has even changed. And recently they rebranded as True Merit. And so they're sort of been expanding the ways that they verify credentials for healthcare professionals, including nurses and other people too. So it's just been interesting watching all those changes evolve over time as immigration has changed and as different labor demands change.
So there's a question in the comments that Bill has already started to answer, but we can open up. Thomas Morgan asks, would anyone comment on the echoes of eugenics and Trump's bad genes and poisoning the blood of the nation rhetoric? Not only are immigrants vectors for the spread of disease in toxic Trump rhetoric, but also for the propagation of bad genes. So that language, Bill, did you want to jump on that?
Sure. And first, Thomas, I tried to answer in text, and then I realized that put you into the answered columns. So my bad. I did want to answer this one live. Andre used the word contagious earlier, right? I think that's exactly right, Andre, talking about immigrants as contagious vectors. But one thing that is often missed with the word contagious is it sounds like we're only talking about disease, but we're also talking about this moral contagion, right? Like this flawed morality is going to be passed on. And to Thomas's point, this idea of poisoning the blood of the nation and bad genes, and you remember Trump even proposed racehorse theory, or the theory of selective breeding to reach the top, goes back to this idea that immigrants, to biological inferiority, biological determinism, in which certain racial groups are inherently biologically inferior, right? We just saw another references to this when he said it was something about, I believe, Mexican farmers like to work in the farm and they won't get hurt even when they work all day. You remember the book by Seth Holmes, Oaxacans like to work bent over, right? Talking about this idea. But yes, to go back to the point that not only are we passing on inferior gene or inferior infection, but also inferior genes and inferior cultural beliefs. And it is fundamental in getting the public to buy in to what is a blatant whitewashing of the U.S. population, right? A blatant use of the deportation machine to increase white homogeneity among the U.S. population is what I meant to say. We even see former ICE Director Tom Homan, who is the current border czar of DHS, admit to racial profiling, right? There's very clear evidence, I'm sure others can talk about racial quotas as well, of using this as a tool to whiten the U.S. And in order to get the public buy-in for this, we see this constant pushing of the idea of biological determinism and bad genes.
There's two that I think we can bring together here, which is Kane Jordan is asking about really I'll read the whole thing, but some works that come to mind from the conversation were Nyan Shah's Contagious Divides and May Nai's Impossible Subjects, as well as some newer work from the Homie Esquivel on immigrant labor and the Braceros program. So can you all talk about the potential stress and negative health outcomes from the constant threat of deportation? And how could we think about this phenomenon historically? And I do want to pair that with Richard Del Rio's question down here, which is wanting to know more about the impact of policies on children's health, whatever their legal status is, Is the effect similar to that of the children of incarcerated parents, or very different? And then we can, I'm sure, historicize that as well.
I'm happy to start. I think Kane, this is such a good question. What's the potential stress? What happens when you live under this kind of stress for so long? If you all are familiar with the work of Dr. Nicole Novak, she graduated from SPH, Department of Epidemiology, the same time I did. And she did this study on the Postville, Iowa raid. So this was formerly the biggest raid, single site work site raid in U.S. history prior to the raid in Elabelle, Georgia. 298 people detained. And she looked at the birth weight of Latino and white infants before and after the raid. And what she saw is that there was lower average birth weight among Latino infants, or infants born to Latino parents and mothers, than there was among white infants, right? So there was this birth weight gap when the raid occurred in the middle. And this happened not only in the area of the raid, so it's not directly related to the removal of those parents, but it happened throughout the state. Now, why did it happen throughout the state? Because as those of you in I guess, throughout the country, but especially in Midwest areas, you know that when an immigration event happens in one place, you know about it through the whole state. So it was the awareness of this raid that actually changed these infants on a biological level, their mothers and then the infants on a biological level, so that the weight of the raid actually manifested itself in the next generation, right? So I say this to point out that the impact of navigating this much trauma is not felt only on the person, but also on the next generation of those communities. We see, as I gave the other example, a large school gap, absenteeism, and test scores go in the direction you would guess among Latino communities. Birth weight goes down, and then you see constant hypervigilance among communities preparing for deportation. In my work, I always get pushed on, do folks have PTSD? And PTSD requires an end to the trauma source, right? So when we think about PTSD as something that came from a war diagnosis, the hypervigilance that served a community well, that served soldiers well in Vietnam, was not beneficial in the US, and hence they were diagnosed, among other factors, with PTSD. For immigrants, there's $44 billion a year being pumped into their removal. So there's no post-trauma here, right? So we even find ourselves needing new types of diagnoses because this hypervigilance that is wreaking havoc on the body's cortisol and adrenal system is actually very adaptive. In communities, they know either I am hypervigilant and thus, cut years off of my lifespan, or I will get separated from my family. And they're making this decision, right? Weighing the odds of health for themselves and their family. So, to answer the question, it is long-term, it is multi-generational, and I think we still do not know the full impacts of what's going on right now.
So, all of you, if you could correct one common misconception about the relationship between immigration and public health, either historically or something that you hear today, and what would it be? What should people know, especially bringing your historical expertise to us?
I think there's this false conception that we've seen from the 1880s with the Chinese Exclusion Act to today, where the immigrant replacement situation, that of course, immigration, labor, that taking over US jobs. And what we have seen over and over and over again is that is absolutely not the case. So in the work that I do, if this latest executive order is designed to shore up domestic production, well, if that is the case, it's going to take at least 25 years in order for that to happen, because it takes 25 years in order to make a physician. And when you are gutting and decimating any, education, any STEM education, you're making universities extremely expensive, medical schools, medical education, cost prohibitive. That's just absolutely not going to happen. And so in the meantime, what is going to happen is that for at least 25 years, those people that are low income, that are on the margins of society, are going to continue to suffer. And they'll just be collateral to this kind of mistaken America First ideology that is not going to yield the results that it is touted or wanting to actually achieve.
Yeah, Rachel, I think two things. One is that mass deportation requires mass public consent. And I want folks to think about that in the future, that if we're going to operate at this speed and try to deport 1 million people a year, as was proposed by Stephen Miller, that we're all going to have a moment where we consent to it or we say nothing, right? So it's not just going to happen. How are they going to gain public consent? That's what we're discussing here. Immigrants as disease vectors, immigrants as biologically inferior, immigrants as dangerous, right? That those narratives you hear on the news are meant to gain consent for violent mass deportation, right? It's our job as public health professionals to point holes in them and talk about why they're false. If I can briefly answer Chris's question too, and this reminds me of Hoel's work. So, Chris, I think one of the things I do, I think about that changing face of public health all the time, right? How is public health going to support the harm caused by a deportation system funded by the government, right? Both from the same hand, as a matter of fact. Often we'll have to do this underground, and often we'll have to cross-organizing movements, right, and do this organically. So Alligator Alcatraz, I hate the name and I'm sorry to say it, but if you remember the advocacy that closed Alcatraz was done by indigenous communities for environmental violations, right? So we see the humanitarian argument, unfortunately, was not able to move the court, but the environmental argument was. And that's exactly what we're going to have to do. We're going to work organically, often underground, perhaps unfunded, and across movements, including immigrant rights and environmental, which, as Joel has pointed out so well, are intimately interwoven, right, throughout our country and throughout the world.
And to build on that, I think, and to also maybe answer the question, is doing away with this idea of American exceptionalism. One thing that I am finding super interesting in the creation of these public health agencies, the CDC, the EPA, is that these very famous figures who are pioneers, quote unquote, or, almost placed in this pedestal of like being a savior of understanding a certain disease in the US. I think there's this idea that everything that comes about and learning about a disease and finding a solution comes strictly from Western countries, especially in this case in the US. And also this idea that nations, in this case the US, doesn't have to rely on countries that neighbor them. In my project, it's Mexico. So after the Second World War, the US-Mexico Border Health Commission and the US-Mexico Border Health Association is formed to not only think about the US-Mexico border as a geopolitical divide, but also an epidemiological zone, meaning that diseases that are shared between both communities are kind of tackled by public health officials, politicians, academics on both sides of the border. And there's this figure, his name is Julian Chisholm, who was like this expert on lead poisoning in Baltimore. And he knew the ins and the outs of how children who were exposed to lead paint reacted. And when this pollution issue that involved lead poisoning was happening in Mexico, in Ciudad Juarez, he was kind of downplaying what children were experiencing. In this case, like they went mute, or there's lead found in blood samples, and their body started to decompose. And even these pioneers such as Julian really began to kind of question the reality that people were experiencing on the other side of the border. And I think maybe to answer the question about how do we reckon with talking about the troubled histories of these public health agencies while recognizing their importance, is kind of writing about them critically, but also finding their worth. And for me, I'm deep in this critique about the EPA, but also recognizing its importance today. And I think doing the paradoxical work of writing these histories that say, hey, this agency was very important and is important today while it's being, defunded and gutted. We can talk about the troubled histories in order to kind of think through futures that include all marginalized people. In this case, children, in this case, and also indigenous perspectives. Part of the study that I'm looking at in my dissertation mentions the Indian reservation, but there's no mention of indigenous peoples in kind of the results or the diagnoses of what is actually happening to their environment and to their bodies. So I think just continuing the work that a lot of us are doing and that a lot of us have done or people have done in the past, I think is it's one tool that continues to work. And that would be how I would think about things.
There's a lot of misconceptions about immigrants that are floating around in my head that I can't land on one, but I'm remembering Aram had mentioned earlier, like with physicians, and I think with nurses too, migrant nurses from the Philippines. I think there is a misperception or the stereotype of like a docile or passive temperament among this sector of immigrant laborers, and I really like Bill's comment about, this only happens with public consent. I think something that history can show are these stories of resistance and of collective action. And I think the sort of stories that I've been able to be exposed to by studying Filipino nurse migration historically has been about that, whether that's been labor organizing or coalition building to advocate for nurses who find themselves in exploitative situations, or legislative advocacy. I think that there's a lot of power there that I think is I think that's something that we can't forget, and that's very useful for resisting the sorts of xenophobic and nationalistic rhetoric that we've been around the past couple of years. So that's one broad swath thing that I think that history is useful for in addressing some misconceptions about migrant laborers.
Well, I want to thank you so much to the panelists, but I also want to thank you all so much for sharing your perspectives, and thank the audience for bringing such great questions to us today. To thank the AHM History of Medicine Committee, especially Committee Chair Scotty Bueller, to thank the Consortium for the History of Science, Technology, and Medicine for your technical support today.
This has been a podcast from the Consortium for History of Science, Technology, and Medicine. For more information on this topic, as well as other podcasts, working groups, fellowships, and resources for learning, research, and teaching, please visit www.chstm.org.